Welcome all of you to this live program on orthopedic principles. Today, our guest of honor is Dr. Sarav Shah from Boston, Massachusetts. Dr. Shah is the Chief of Sports Medicine and Program Director at the New England Baptist Hospital in Boston, Massachusetts. Dr. Shah received his medical degree from the Drexel University College of Medicine and completed his general surgery internship and orthopedic surgery residency at the Long Island Jewish Medical Center. He completed sports medicine fellowship at the New England Baptist Hospital in Boston again, as well as fellowship in shoulder and elbow at the Hospital for Special Surgery in New York. If you've noticed, Dr. Shah has delivered several lectures on the channel, and it's already reached a huge audience. And today is my great honor to bring back Dr. Sarav Shah for this wonderful live program. Over to you, Sarav.
Thank you so much for the wonderful introduction. Today, I've been tasked to talk about our recent publication, trying to figure out an appropriateness criteria algorithm for Anatomic to streamline the decision-making process. This has been a long-standing project of mine. Let's get into it. So, we have the total shoulder domination, historically anatomic domination. The reasoning is prior to pre-2004, the reverse was not FDA approved. There was data that suggested high satisfaction rates, but they may not necessarily account for long-term function. And then you have the complication rates that were reported for reverse in Europe. Global problem rate was 44% reported, complication rate 24%, reoperation rate 3.3%, revision rate 10%. Again, this was 2011 though, okay? And then newer data, with the advent of modern surgical techniques, the advent of the biomaterials, better surgeons, better techniques, better training, the reverse and better, kind of the next evolution in science, the reverse got better. So, modern implants, primary reverse, low reoperation rate, 2.3% versus 10% revision rate in the prior Zoom student study versus our studies. I ended up doing 2 systematic reviews looking at the modern reverse in the modern decade. So from 2010 on, with the use of non-modern prosthesis, complication rates were significantly decreased. We looked at all specific complications across the board: scapular notching, dislocation, base plate loosening, neurologic injury, the whole gambit. All 8 of the most common complications for reverse, everything was significantly decreased down to less than 1% for each one. In terms of, other than scapular notching, in terms of dislocation was 0.9% for the on-light prosthesis, and so on and so forth. We had about 9,000 in each of the systematic reviews, total numbers. So big numbers. And then you look at, then we started to analyze and kind of, I would say, better identify some of the problems with the anatomic, right? Humeral overstuffing. Numerous clinical studies show the shift in center of rotation can lead to increased forces across the joint. Subscap failure, we know about. Here's an X-ray showing on the axillary, the head's facing the front, so you're kind of suspicious for a subscap failure. Superior rotator cuff, that's kind of the big knack on the anatomic. The Young study came out, and then multiple systematic reviews afterwards. Average of 8.5 years, dysfunction of the rotator cuff in a high number of total shoulders, anatomics. 16.8% is pretty high. Systematic review of 1,200 anatomics had average 6.6, 30% had superior migrated humeral head, so not kind of what we're looking for. And then so the explosion of reverse, again, at many institutions, pendulum has kind of swung, and the indications have expanded, which also kind of contributes to the success of the reverse. Right now, we do it for proximal humerus, we do it for rheumatoid, osteoarthritis with an intact rotator cuff. Obviously revision, but the indications for reverse is pretty much a catch-all. And the broadening of the indications have resulted in the reverse now in the country is now surpassed anatomics as the most frequently performed shoulder arthroplasty. This is kind of a diagram, kind of what we talked about. The modern advances, allowing the increase of the spherical radius, changing the neck shaft angle was a big deal, going from 155 to 145 for most of the onlays, 135 in the inlays. Creating the inferior overhang, depth of the polyethylene. And I think what's kind of being lost sometimes is the biomaterials are better. The early reverse didn't have locking screws, right? Without locking screws, it becomes a very difficult proposition for the reverse. Those types of biomechanical successes have allowed the reverse to prosper as well. But hold on, that's where we gotta everything comes with a grain of salt. Everything is looked at under the patient-specific lens. So this was my paper we did at HSS. Patients aged 75 and over, patients achieving MCID were similar. However, a higher percentage of anatomics achieved substantial clinical benefit, which is two standard deviations beyond the mean compared to reverse. So, in the this study highlights the idea of shared decision making, patient specific, and indications. You got to nail the indications to optimize patient satisfaction and patient outcomes. So if the patient is, kind of on the younger side or thinks they're younger and they're a weightlifter or they're active and they don't want to give up, kind of the restrictions that come with the reverse, it's still viable. And, these outcomes kind of show that. And then you say, okay, biology, we have biological augmentation. So if the subscap failure is an issue, why can't we augment the subscap with bone marrow aspirate? So my partner and I, Glenn, we did this study looking at bone marrow aspirate concentrate injected into the subscap to augment the healing. We have 6 months now on ultrasound. This was the technical paper, but we have 6 months now on ultrasound. We're waiting for 1 year to be able to publish those data. And then the stemless. So stemless has kind of reinvigorated the anatomic. There are a bunch of, kind of good data, good studies to show that if you take the stemless out single stage, you can convert to a reverse with bone grafting the glenoid, by the way. But single stage, there's some radiologists out there that will not be able to tell that it was a revision. It looks like a primary reverse with a longer stem, but looks like a primary reverse. So getting to the project at hand here that I was kind of passionate about getting this done. So appropriateness criteria evaluating winter before anatomic is lacking. There's not really anything in the data before this. Given the rise of utilization, appropriateness criteria for anatomics have the potential to be extremely powerful for improving quality of care and controlling costs, especially in lower volume centers across the country. The goals of the project is to test the explicit criteria to assess the appropriateness of total shoulders anatomics using this appropriateness methodology. It's the RAND UCLA method. And then number 2, compare the appropriateness to real world surgical cases. And then number 3 is compared to outcomes. If outcomes make a difference in the appropriateness groups. So part 1 was validation and algorithm creation and validation. So this was our paper that was published. This was the part 1 in JSES. So we took 2 panels. Panel 1 was 5 ASCS candidate level or above, 2 shoulder fellowship directors, chief of shoulder surgery, and 2 high volume specialists. And then panel 2 was 7 total members, 1 fellowship director, 1 director of research, and 4 high volume specialists with 1 international specialist. So they went head to head in this anatomic total shoulder appropriateness criteria algorithm development. We created fictional vignettes. These vignettes were based on specific kind of what we thought were different indications, different variables that will play a role into whether we would choose to do an anatomic or not. And you can see some of the examples here, but specifically, we looked at age as a big thing, symptomatology, mobility, SP, the Semilio Plateau, can never pronounce that classification, but whether they had an inferior osteophyte, how big was the osteophyte classification, and then Walsh classification, et cetera, and that's how we kind of debated whether it was appropriate, inconclusive, or inappropriate as the 3 main outcomes of the algorithm, but they were scored. And here's just an example of the vignette. They're scored, and here's the kind of flow diagram. So you have that vignette. They're given a score 1 to 3, 4 to 6, 7 to 9, and then we have to determine agreement. And if there's agreement or not, then it determines what ultimate final scenario rating they get between inappropriate, inconclusive, and appropriate. So here's what we got when we separate. The main separation was symptomatology. So in the slight symptomatology, this is what we came up with. Pretty much nothing is consensus for appropriate for anatomics. Moderate symptomatology, if they had limited mobility, a Walsh 1, limited mobility, Walsh B1, there was agreement that we would do appropriate for anatomic. Severe symptomatology, that's where we're kind of, make our bread and butter here. We're looking for lower grades of deformity, so preserved mobility, but lower grades of deformity with severe symptomatology, pain-wise, then that was deemed appropriate. Limited mobility was not deemed appropriate. That's where most people would tend to go reverse. And then limited mobility on the B1s, we were pushing for anatomic because theoretically then I haven't switched over to the B2 with retroversion. So part one takeaways using the RAND UCLA method. And there's obviously some variation in this too, right? They weren't giving, the vignette was not, here's a patient with limited mobility, B1 glenoid, what are you going to do? It was a vignette style where it's a paragraph. So there's some nuances, and the age groupings and everything, it's all nuanced. It's not, 75, you don't get the grouping, you get a specific age, 77-year-old female. So there was some variability, and that played out a little bit in some of the ratings. So part one takeaways, the ASCS members, we developed this decision tree to determine appropriateness total shoulders across a wide range of pertinent indications. The tree can be used as part of the toolbox, not the sole determinant, but a part of the toolbox alongside individual patient factors, current literature, expert opinion to inform clinical decision making, improving quality and cost across the board. And then the high proportion of both scenarios and indications were classified as inconclusive, and that kind of goes with the national kind of modern debate of anatomic versus reverse. So it kind of fits the bill. Part two, we could actually took real world cases from the ExactTech database and inserted it into the algorithm and see, how many were actually cases that were actually done, how many of them from our algorithm would be deemed appropriate, inconclusive, or inappropriate. So this was that paper. Roche is the PhD from ExactTech. He contributed the data from it. So here's just the data outlook. We had 775 patients that were done, so large group that we can actually derive the data from. So the take home from a large portion, only 24% were deemed as appropriate, while a large proportion were deemed inconclusive. So that's kind of the modern debate of anatomic versus reverse here. But the kind of underlying messages, 18% were deemed inappropriate. So, there has to be some back and forth and consideration for what the line is and how we can streamline this to keep the anatomic, from being, for lack of better words, badmouthed more in the literature, because it does play a role. It's largely based on patient indications, age, and your discussion with the patient, right? Shared decision making. So considerable variation in characteristics, patients undergoing anatomics, largely driven by age, symptomatology, and then Walsh classification. Those are the three main factors that change the classification grouping in terms of inappropriate and appropriate. We already talked about a significant number were inconclusive, secondary to worsening glenoid morphology, history of cuff repair. There was a debate, especially in the surgeons in the group from the included outcomes data, surgical data, I should say. Some of them were more kind of aggressive in terms of doing the anatomic in a prior rotator cuff repair setting. But that's a modern debate where, a lot of the maybe younger guys or people who are trained more recently may not have that kind of leniency and allotment of prior cuff repair into this. The appropriate patients that we thought were appropriate in our algorithm from the cases that were done did tend to have worse preoperative function and pain scores. So that can portend, that's probably fits the bill of why they'd be more appropriate. So part three it was the whole kind of the point of doing all this is to actually correlate with the outcomes here. Do the outcomes vary across the groups of appropriate, inappropriate? So this is the paper that was just published in Bone and Joint Journal. Clinical outcomes do validate the algorithm. And in our paper, here's the outcome measures. So in total, we had almost 400 patients. Large majority were inconclusive as the other prior two studies, but the appropriate patients were 97. But I'll call attention to the ASCS score difference. And what we deemed appropriate for the cases that were done, their outcomes had a greater delta. They had a larger increase in ASCS score than the other two groups, and 0.004, so largely significant. And then, so like we just talked about, greater improvement in VAS and ASCS scores compared to inconclusive and inappropriate. This appropriate group had a significantly greater proportion of patients who achieved MCID, which is 1 standard deviation better than the average, but also SCB. Almost 93% had achieved SCB in the appropriate group. So it's pretty powerful stuff. If you follow the algorithm, these people will 93% will achieve 2 standard deviations better than the average in terms of improvement. So, that's how we can kind of modernize the anatomic, in my opinion, keep it from becoming a relic, if you will, a relic procedure. Despite, even me, being a hard advocate for anatomics, even in my practice, I'd say it's still probably 35% anatomic and 65% reverse. In the country, it's kind of, there are many surgeons in the country that are just no anatomic, period. Including a couple of my hospital. So the part 3 takeaways: about 400 patients, average follow-up of 48 months. Appropriate patients were more likely to achieve MCID, and SCB for ASCS scores compared to the inappropriate patients. And kind of the discussion people have is, what happened to the other 4%, the 6% that didn't achieve SCB? So among the appropriates that didn't achieve SCB, 50% of them had a postoperative complication, right? So the complication still exists. This was a significantly higher proportion of postoperative complications among those that did not SCB across the whole group. So only 7% of patients who did not achieve SCB in the inappropriate group had a complication versus 50% of the ones who didn't achieve SCB in the appropriate group. So it can be inferred that the failure to reach SCB, substantial clinical benefit, in the appropriate group was likely due to postoperative complication, whereas for the patients in the inappropriate group, failure to achieve SCB may be secondary to factors accounted for within our algorithm. So bottom line is, the patients who didn't achieve SCB in the appropriate group did it because of a complication, not because they were inappropriately indicated. Is kind of the read from the PC way, the politically correct way of writing it out in the paper. Other takeaways: all 3 groups did have an improvement in the mean patient-reported outcome score. So that's still, it's not a bad procedure. These weren't inappropriately indicated. They weren't, done for the wrong reason. There was no malice. They all achieved significant improvement in their patient-reported outcome scores. But, as surgeons, we don't strive for just better. We want the best, right? So 2 standard deviations above the mean, you're in the other of the bell curve. You're on the outside of the bell curve. You're within the top 5% on that in the SCB. So the data clinically validates our appropriateness criteria for anatomic total shoulders, allowing for more rapid and reliable determination of anatomic candidacy for patients. Overall conclusions: these 3 studies' data provide a convincing argument for consensus-building efforts to delineate eligibility for criteria for anatomics, particularly in modern debates in surgical decision-making for anatomics versus reverse candidates. And then these studies may allow for a reduction in variability in patient selection, optimize outcome, improve implant survivability when you're selecting patients better, and also cost effectiveness. Thank you.
Thank you, Sarav, for this wonderful.
Thank you.
Yeah.
Any other questions? Yeah.
Sarav, you can hear me?
Yeah, I can hear you. Can you hear me?
Yeah. Thank you, Sarav, for this crisp presentation. Let's take a few questions.
Yeah, go for it.
Yeah. Sarav, the disease pathology itself, right? Can we make a decision based on that? For example, someone who has a rotator cuff tear arthropathy goes for the reverse, and someone who has a primary glenohumeral arthritis goes for anatomic. And rest all, you decide based on the other factors like age, what are the factors that you mentioned, age, wall stack, and symptomatology.
No, I think the debate has gone the other way. The debate is everything goes reverse, and then you try and figure out what can survive as an anatomic. So it used to be primary OA with an intact rotator cuff would be anatomic, but we're finding out in this data that subscap failure, supraspinatus failure, glenoid failure is kind of going away with the newer implants in terms of anatomics. But the success, there's a smaller standard of error, right? There's a smaller leeway for error in the anatomic versus the reverse. So if there's any doubt, most people try and go to the reverse. That's why this way in the algorithm, you're able to kind of streamline it and pick and choose which ones will do the best to optimize who you choose to do anatomics on.
And which, according to you, is the ideal patient for an anatomic?
For me, in my practice, it's 55 and under. If I'm doing anatomic, they all get stemless. Intact cuff, obviously. Good range of motion, and moderate to severe symptomatology.
And the disease pathology, cuff tear versus primary glenohumeral, does it matter?
Well, cuff tear is definitely in reverse. Yeah, it has to be intact cuff. Intact cuff, no history of repair, nothing. So I did one anatomic on a patient who had a history of an open Bankart, but even then, he lasted 7 years. So it's still not, you take a chance and you put the augment, your BMAC augmentation is still not 10 to 15. So, I've kind of gone away. If you've hit any history of anything rotator cuff wise, you get a reverse.
Okay, so the tendency would be among most surgeons would be to do a reverse, right? In the US?
Yep.
I've hosted a lot of surgeons.
In the country, I think it's 70-30 reverse in the country.
I mean, the older surgeons would, interestingly, I've hosted Professor Frederick Madsen, and he was a big advocate of the total shoulder rather than the reverse.
Yeah, well, Rick Madsen, he's a legend, right? I mean, I would strive in my life to be like him, right? He's in the Hall of Fame. He's very, very talented, very intelligent, very good. I think his results are unique to him somewhat, right? I mean, but in the long run, there are many, even the older generation of surgeons who are strictly reverse, right? Richard Friedman, right? Friedman, he only does reverse. He does not do any anatomics anymore.
Sarav, interestingly, what I hosted someone recently, and we had a debate about a massive irreparable cuff tear with a pseudoparalysis. There's an anterior superior escape. So would you go for an arthroplasty? I mean, an elderly, some above 50 or 60 years of age. Would you prefer doing an arthroplasty or do some sort of muscle transfer?
I do a bunch of lower trap transfers, low trapezius tendon transfers. You really got to be careful on those tendon transfers. If they don't have range of motion, I go 120. Boston's paper said 90. If they don't have more than 120 of elevation, that's not a lower trap. That's not going to come back. That's going to be a reverse. And then again, looking at indication.
You mean passive range of motion, right?
I mean active range of motion. Active range of motion.
Okay.
They have to be able to lift a little bit. If you're coming to me and you're like here, you're not getting a tendon transfer. You got to be at least 120. I call it high five range. You got to be at least give me a little high five to be able to give you a tendon transfer. Because you got to realize the amount of healing that has to happen biologically for the lower trapezius tendon. The Achilles has to heal to the humerus, plus the Achilles has to heal to the actual lower trap muscle belly, pelvic calf weave. Those are two connections that take a lot of biology to heal. If you don't have enough deltoid retraining to lift your arm, you're not going to be able to survive the tendon transfer. Then you come back for do the reverse a year and a half, 2 years later anyway.
Great, Sarav. Sarav, I think that's all the questions that we have for this session. And congratulations for this wonderful paper in JBJ's British, right?
Yes.
Bone and Joint Journal. I'm sorry.
Bone and Joint is a new name. Yeah, new name.
Okay. Thank you so much for joining, and really look for more in future.
Appreciate it. Thank you.
Bye. Thank you.
Bye-bye.